Good evening or good night, everyone. Can you hear me?
Good night, Dr. Harris. We can hear you.
Okay. I'll try to put this in presenter view. Is it still okay? The screen?
Yes, it looks okay.
Right. We met yesterday. I'm Ardeen Harris, medical epidemiologist in the National Surveillance Unit at the Ministry of Health and Wellness. And tonight, we're going to change focus and look at maternal morbidity and mortality and the implications for service delivery. Now, based on this first slide, we note a chart showing the maternal mortality ratio from the 19th century up to the 21st century. And we note that it was over 600 per 100,000 live births. And at the time, we had slavery. There was no intervention made because we had a steady flow of slaves coming in after the abolition of slavery, though you had more interventions being made to reduce the number of children who die, number of slaves, or even after emancipation, number of persons who were, no, not emancipation, I'm mixing it up, where after slavery was abolished, they started to focus on trying to keep the ladies alive because those were the ones who would be able to replace their workforce. And the British had a way of keeping the records. And so, if we're to believe the records, then there was a steady decline in the maternal mortality ratio over time in the post-slavery era. And now we're trying to get it back down. We still have an increase after the early 2000s, and we're trying to get it back down. I want to give credit to Professor McCall-Binns. She would usually do this lecture, so she did share her slides. A few years ago, she handed it over because she's now retired, but she was Professor of Reproductive Health and Epidemiology in the department there, Community Health and Psychiatry. So for tonight, we want to define some key concepts as it relates to maternal health and fertility, morbidity, and mortality, and look at the historical context of safe motherhood. Also introduce global efforts to measure maternal morbidity and mortality as well, and look at the changing profile of women of reproductive age. Look at the maternal mortality surveillance data from when we started doing the surveillance of maternal deaths to present, and also look at the application of the maternal death surveillance and response framework to Jamaica. Why are we doing maternal mortality surveillance? Well, we do want to reduce or eliminate the occurrence of preventable maternal deaths. So if we're trying to do that, then we have to find some way of tracking it. That is one of the goals, to track that indicator, the maternal mortality ratio. It is Sustainable Development Goal 3.1 is to reduce the global maternal mortality ratio to less than 70 per 100,000 live births by 2030. So we have to track that indicator. But beyond that, though, we look at what caused the deaths. In surveillance, we look at what caused the deaths and what might have occurred, what could be done to prevent the deaths, so we can know where to allocate resources addressing the major causes of death and also addressing the major factors that led to the death of these women. So let's look at some definitions. If we look at a pregnant woman, then generally most of the pregnancies will be uncomplicated. The women, they deliver, they go home healthy with their baby and are able to care for their newborns. But some pregnancies are complicated. Among the pregnancies that are complicated, some women recover from those complications without any problems, and those complications are not life-threatening. But then there are complications that may very well be life-threatening. If they are life-threatening, then some of those actually, even though they are life-threatening, the women actually survive, and those we'll call the maternal near miss. But among the life-threatening conditions, some women actually do die. So that is the spectrum of maternal morbidity, from uncomplicated pregnancies on one hand to maternal deaths on the other end of the spectrum. If we look at maternal ill health, so we have maternal near miss, and the definition for that is a woman who nearly died, but she actually survived the life-threatening complication. And that complication is one that occurred during pregnancy or childbirth or within 42 days of the end of the pregnancy. Now, when we say termination of pregnancy, we're just saying the end of the pregnancy, whether it ended in a miscarriage or abortion or live birth or stillbirth. Just the pregnancy ended, so the woman is no longer pregnant. And 42 days that's about 6 weeks after the end of the pregnancy. And we look at maternal morbidity. So when we talk about morbidity is ill health, and mortality would relate to deaths. So maternal morbidities, any health condition attributed to or complicating the pregnancy that has a negative impact on the woman's functioning or quality of life or capacity to carry out her daily activities. That's maternal morbidity. And maternal morbidity may be due to a direct cause. And direct cause is a cause that is directly related to the pregnancy, such as postpartum hemorrhage. So she might have had postpartum hemorrhage leading to anemia, so she's not able to function as well as she could. Or you may have an indirect cause. So the cause is not directly due to the pregnancy. So she can have these illnesses even if she doesn't become pregnant, like sickle cell disease, HIV. Or it can be totally unrelated to the pregnancy and not aggravated or exacerbated by the pregnancy, like allergies or non-hormonal cancers. So the hormonal cancers, because of the physiological changes in pregnancy, they tend to be aggravated by the pregnancy. I must say that I may not see any raised hands, so if you want to ask a question or make a comment, just go ahead, open your mic, and you can make a comment. For adverse maternal health outcomes, we're really talking about the deaths now. So pregnancy-related deaths are deaths due to direct causes or indirect causes or coincidental causes that occur in a woman who is pregnant or within 42 days of the end of the pregnancy. So can be direct, indirect, or coincidental. However, if we're speaking about maternal deaths, it has a specific definition, and these will therefore only include direct or indirect deaths. So it's a death of a woman while she's pregnant or within 42 days of the end of the pregnancy, irrespective of the duration of the pregnancy, irrespective of the site of the pregnancy, and from any cause that is aggravated by the pregnancy or related to the pregnancy. It may also be related to the management of the pregnancy. For example, if you're trying to do, if it's related to the anesthetic, if it's related to, if she's on mechanical ventilation and she died as a result of ventilator-associated pneumonia, if she wasn't pregnant and we weren't trying to ventilate her because she suffered some complication during the pregnancy, then she would not have died, then it is going to be deemed a maternal death. So it's from a direct cause or indirect cause, not from incidental causes, and it occurs in the woman while pregnant or within 42 days of termination of the pregnancy. Now, beyond the 42 days, then we call it the late maternal deaths from direct or indirect causes, and the complication or whatever caused the death arose during the pregnancy or during the puerperal period, that's within the 42 days. But the woman doesn't die at that time, but dies after the 42 days, but up to 1 year of the end of pregnancy. Not going to get into that, but there is another category called obstetric sequelae, which is beyond the 365 days. That's after the 1 year mark. But we don't track those here in Jamaica. So we're looking at pregnancy-related deaths. Those are the direct, indirect, and the coincidental ones. So it takes into consideration all of them. For the direct ones, the complication is as a result of the pregnancy. So if the woman did not get pregnant, then she cannot die from these causes, like preeclampsia, eclampsia, postpartum hemorrhage, or antepartum hemorrhage. If she wasn't pregnant, this would not occur. So we call it a direct death. The indirect ones are usually medical conditions that are worsened by pregnancy. And the late maternal deaths may be direct or indirect, but they are beyond the 42-day mark. So between 43 and 364 days post-delivery. And you have the coincidental deaths, which are due to accidents, violence, so from motor vehicle accidents, gunshot wounds, some arson, then those would be classified as coincidental. Now, suicide is in a special category because it's considered direct, but we don't usually include it in the calculation of the maternal mortality ratio. We don't see that so often here in Jamaica, thankfully. But when it does occur, it's considered direct, but just not included in the calculation of the maternal mortality ratio. All right. Other definitions, the total fertility rate is the average number of children that's born to a woman, that would be born to a woman over her lifetime. If she experienced the exact current age-specific mortality, age-specific rate, that's the fertility rate, and you basically do it by summing the single year age-specific fertility rate. Now, for example, you do the age-specific fertility rate for women 20 to 24 year. Well, we would start at 15. So 15 to 19, 20 to 24, and you sum them to get the total fertility rate, because for the reproductive years, it's considered 15 to 44 years, but I think WHO uses 15 to 49 years. So other reproductive health indicators, we track the contraceptive prevalence, that's the proportion of women using a reliable modern contraceptive, the adolescent fertility rate, that's age-specific fertility rate among women who are under 20. And we also look at the proportion of women who make at least 4 antenatal visits during the pregnancy. And we look at the proportion of births that are attended by skilled birth attendants. This would be midwives, doctors, or nurses trained to provide basic emergency care. In Jamaica, we track the pregnancy-related deaths, so direct and indirect maternal deaths, late maternal deaths, coincidental deaths, up to a year of the end of the pregnancy. Right, on to some calculations now. Now, you would have been taught about a ratio versus rate. So for the rate, what's in the numerator should be included in the denominator. So the maternal mortality ratio is the number of maternal deaths, and that's those that are direct or indirect while pregnant or up to 42 days of the end of pregnancy. And that's divided by the number of live births. So what's in the numerator is not in the denominator. So it's a ratio, and that is the primary indicator. I told you it's Sustainable Development Goal 3.1 to reduce the maternal mortality ratio to less than 70 per 100,000 live births. And if you're talking about the rate now, then it's the number of maternal deaths divided by the number of women of reproductive age. And we use the mid-year population for women between 15 and 44 years. And as I say, some use 15 to 49 years, and that's okay. Now, the general fertility rate is the number of births in a year divided by the number of women of reproductive age in that year. We use the mid-year population again, and we have different factors that we multiply by. For the maternal mortality ratio, it is per 100,000 live births. So we multiply that one by 100,000. That is one of the main indicators that we use and that we track. Remember, just stop me if you need to ask any question or make a comment. All right. Now, we have what we call the obstetric transition over many years, and I'll indicate where we are in the transition. Some countries are ahead, more ahead than others, but I'll indicate where Jamaica is. So the obstetric transition, and I know you learned about the epidemiological transition and so on. So when we talk about the obstetric transition, it's the movement from high to low maternal mortality. And what is occurring is that we have more indirect or non-obstetric deaths. So these would be most likely due to non-communicable diseases. We see that women who are having children, we have an increasing number of women who are having children later. We have more institutionalized care, so less or fewer home deliveries. We have more obstetric interventions and maybe over medicalization, so increasing the C-section rate and so on. So this has implications for the strategies that will be used to reduce the maternal deaths based on what is happening. Now, long time ago, and I don't know of countries that are above 1,000 per 100,000 live births, but long time ago, you had high fertility and high mortality, and you have had a lot of direct deaths, but you also have a good contribution of communicable diseases. And that was stage one. Stage two, the maternal mortality ratio between 999 and 300 and 999. And in that phase, you still have high fertility, you have high mortality as well, but there is still the transition to women seeking more facility-based care. But there are issues with access to the care, training of skilled birth attendants, and some African countries have as high as that, and some Latin American countries as well have high maternal mortality ratio, not maybe up to the 900 mark, but more toward the 300 per 100,000 live births. So, of course, the focus there would be on family planning because we still have the high fertility, nutrition, and so on, and strengthening the health systems to be able to care for these women. So stage three is where Jamaica is, between 50 and 299 maternal deaths per 100,000 live births. So fertility is variable here. We still have high or higher proportion of direct deaths, but there is improved access to care. Quality of care is still a challenge. So shift toward secondary and tertiary prevention. So need more skilled birth attendants to manage and the complications of pregnancy when they occur. For stage four, some countries are already there. For USA, theirs is about in the 20s per 100,000 live births for but all right, stage three. Yeah. Yes, US is in this category because it's under 50. So mortality is moderate or low, and there's low fertility, but there is more non-communicable diseases now. So quality of care is good, but there are still delays in the when we talk about the health system, and they now would need to address the high C-section rate because there is usually over medicalization. Stage five, the maternal mortality ratio is actually less than 10. And yes, it is that in some countries. Well, I was going to put Canada in there, but there's the last I saw for Canada, they were at 11. So they're actually in stage four, not there yet. But like Norway, Poland, Germany, and those European countries, theirs is like 4 per 100,000 live births. So that's where they are, stage five in the obstetric transition. And so they are preventing the preventable maternal deaths, but they do have low fertility, so they have fewer deaths to deal with. The deaths are usually due to indirect causes, but there's still challenges with dealing with the maternal mortality ratio in poorer persons or migrants. So that is where the focus then needs to be, right? From a historical context where maternal mortality is concerned, well, I alluded to it earlier, where initially little was done to prevent the maternal mortality, and Then you had training of health professionals. You had persons looking at our maternal mortality ratio and say, is this a true reflection of what is happening? And so it was assumed also that if we're looking at child health and dealing with child health, then that also takes care of the mother. But when we look at the causes of maternal death and the causes of infant death, they are different. So we have to have different strategies for addressing maternal mortality than what we would for looking at child mortality. Then there was probably a turning point where you had the Motherhood Conference in Nairobi in 1987, where there was a call to reduce maternal deaths in low and middle income countries by 50% by the year 2000. Now, the proposed strategies include primary healthcare access, universal family planning, adequate food for females. But if we look at what was actually achieved in relation to that, each achievement was no change in the maternal mortality ratio. And so there was a turn to the Millennium Development Goals. And that was to achieve by 2015 a 75% reduction in the maternal mortality ratio. Very ambitious, and what was achieved in 2015 was a 44% reduction from 385 to 216 per 100,000 live births. And so in 2015, then came the Sustainable Development Goals, and Sustainable Development Goal 3.1 said that by 2030, we are to reduce the global maternal mortality ratio to no more than 70 per 100,000 live births. For the region of the Americas, though, to contribute to that, we're asked to reduce ours to less than 30 per 100,000 live births. Not sure who's looking at that 30, but I think there's still a thrust to at least make the individual contribution to the 70 per 100,000 live births. That's the focus. The 70 per 100,000 live births. And if everybody achieved that, each country achieved that, then we would overall, the global maternal mortality ratio would be less than 70 per 100,000 live births.
Doc, did they give a reason as to why the Americas was so they wanted to achieve less than 30? And then I realized from the Safe Motherhood program coming out, we're getting more and more ambitious. I'm not, I guess that's a good thing to strive towards, but I'm not sure if the barriers are being addressed aggressively to actually be successful in meeting the target, as opposed to 2030 coming and we're not there, and then we push it again to 2050 and we still do address the issues.
Well, I think it's generally understood that everybody will not achieve it. So if those who can actually get to under 30, for those who can't, who are at the other extreme, then overall, on average, we should be there. We should be at 70. But for some of the Latin America and Caribbean countries, we're actually above the average for Latin America and the Caribbean, which is 68 per 100,000 live births. We are above it. Jamaica is above it. Everybody know that Haiti is above it. Guyana, Dominican Republic, Suriname, we are above it, and other South American countries are above it. And I'll show you in the next slide. In 2018, we're at 68 per 100,000 live births. And at that time, based on the maternal mortality ratio for Jamaica, we were told to have a 5% reduction every year to 2030. If we do that, 5%, 5.5% each year steadily, then by 2030, we'd likely achieve the 70 per 100,000 live births. Now, the last one, and this is preliminary data in 2024 at 150.3, and that's where we are, 150.3 per 100,000 live births. If we are looking to achieve the 70 by 2030, we have to reduce every year steadily by at least 12%. This is the metrics. So if we continue to reduce by 5.5%, we wouldn't achieve it. By 2030, we'd be at 107. But if we are to achieve it, we have to reduce 12% progressively. So these are hypothetical figures, right? Because we won't reach there yet. But if we're to achieve it and the reduction is linear, then 12% each year would get us there to the 70 per 100,000 live births. Look at more statistics then. If we are to achieve it, Jamaica should not have more than 23 maternal deaths in any year. And that's based on the average number of live births that we have. And if you break it down by parish, then Kingston and St. Andrew and St. Catherine, they have the highest number of live births each year. So if Kingston and St. Andrew has 6 maternal deaths, based on the number of live births that they have, their maternal mortality ratio would be around 70. So that is how the figures in the second column are calculated based on the number of live births. If St. Catherine, rather, St. Elizabeth has 1 maternal death, their maternal mortality ratio would still be within the 70. And overall, if we work it out like that, Jamaica, if we don't have more than 23, then we should be within and be less than 70. So in 2023, we had 40 maternal deaths, and 2024, 39. And these will be finalized because if RGD indicate that based on 2024 deaths, we find more maternal deaths, then we'll have to add it to 2024. 2023 has basically settled. So in red are the parishes that exceeded their maternal mortality ratio based on what would bring them to under 70. And overall for 2024, for the regions that exceeded it, Sarah, the target would be 10, and they had 19 in 2024, for example. And the southern region, their target was 4, and they had 4 in 2024. So their maternal mortality ratio was about 70. But the other parishes exceeded. So overall for Jamaica, of course, we exceeded that. And so we continue to look to have at least that 12% reduction each year to 2030. All right. Now, looking at epidemiology of maternal deaths in Jamaica and how it's changed over the last 30 years or so. So this is the map of Jamaica. We have the 4 health regions: Southeast, Northeast, Western, and Southern health region, with 3 to 4 parish in each health region. And on it, the cross represent the hospitals, and we have the dots would be the health centers across the island. And of course, Southeast has the highest population, and they have the highest number of births as well, followed by the Southern region, then the Western region, and then the Northeast. And so that is the basis for looking at the metrics about how many maternal deaths would bring the maternal mortality ratio to less than 70. So based on the census population, what we're seeing is an increase in the number of women of reproductive age over the years. Based on the census population, we're still due the results of the latest census, but the bulk of the women is in women of reproductive age. Yes, increasing in the elderly, and so there is focus on elderly health, but the bulk of the population is the working age population, women of reproductive age, so we can't forget them. We have to focus on them and keeping them alive. Now, there is the changing demography, looking at the births by parity. So 0 parity, women who are having their first pregnancy, and then the parity of 5 or more, they've had 5 pregnancies up to the 3rd trimester. So the women, in all women who, whether it's your first pregnancy or 2nd, 3rd, 4th to 6th pregnancy, the women are having fewer babies each year. All categories of women having fewer births. All right. Looking at the number of births by the age, the under 20, those would be the teenage pregnancy. Steady fall from 1980 to present, steadily falling. So we're not having as many adolescent or teenage pregnancies. What's not falling so much is the women 35 years or more. They are remaining round about the same each year. So we're not having a reduction in this age group, but for the younger women or the lower risk women, we're seeing a reduction in the number of children that they are having. Well, if the women who are 35 years or more are having more children or round about the same, then these would be the ones, I would say we would be the ones with the higher prevalence of non-communicable diseases. We'd be the ones with diabetes, hypertension, obesity. And if we look at sequential Jamaica Health and Lifestyle surveys, and for diabetes, as we go up in terms of the age group, the prevalence increases. For the obesity, prevalence increases. Just to highlight that, yes, we talk about the non-communicable diseases, but we also have to look at the other social risk factors in women, and if we ask them about it, they will tend to open up when they come to antenatal clinic about depression, anxiety, about intimate partner violence, and some of them have no partner. So that has implications for the support that they would need to get for during the pregnancy and after the pregnancy. I know that, social workers and that network is not as strong or under-resourced, but these are factors that we can't ignore, especially in the pregnant women. All right, we wanted to turn our attention now to maternal mortality surveillance. Just reminding, if there are any questions or comments, just open your mic and speak. So for the surveillance cycle, we have to identify the cases, collect the information on the cases, do the analysis, make the recommendations, and then we try to implement the interventions, then evaluate and see whether the interventions are making a difference. For the surveillance, it was Graham's society that looked at a range of services to reduce maternal deaths. And in 1980, Victor Jubilee Obstetricians did a review of the hospital deaths and found that there was underreporting of the maternal deaths in the civil registration and vital statistics system that's in RGD. And they did maternal mortality surveys in 1981 and 86. And then in 1998, we started doing active surveillance for maternal deaths. So that's where we have most of the more comprehensive data on maternal mortality. It would be from 1998 to present. And in 2005, it was extended to include the late maternal deaths, that's up to a year after the end of the pregnancy. And included in that also was coincidental deaths. When we do the surveillance and we have the information together, we look at the age, the parity of the women, gestational age, the outcome of the pregnancy, whether the lady died while pregnant, so she's undelivered, or it was a stillbirth, live births. We look at the education, and we are looking to look at not so much now, but in the future to get information on the socioeconomic status, looking at employment status. It's always tricky to ask about income levels, but as a proxy to that, we can look at the occupation and the highest level of education. So we look to collect information on that going forward. We do descriptions based on the area of residence, urban, rural, but more so by the parish, and calculate the maternal mortality ratio based on the parish. The timing of death, whether it has implications, when they occurred, by month, by time of day, whether it was a weekend, because sometimes on weekend we have lower or fewer staff in the institution, and look at whether that affected the care of the women, look at the number of antenatal visits that they attended, the when they delivered, the institution that they delivered at, and whether it was a tertiary level institution. And the information comes from notification, come from what do you call it, the case investigation forms, post-mortem findings, and when they're reviewed, we look at the underlying, intermediate, and immediate causes of death, look at other risk factors and delays in the care of the women. And we talk about the delays in coming up in a few slides. So, the definition for surveillance, the continuous or systematic gathering or collation of data, analyzing, interpreting the data, dissemination of the data. Now for the definition for sentinel surveillance is here, but for maternal deaths, the surveillance is universal. It's passive in the sense that maternal deaths are class 1 notifiable conditions, and so they are to be reported on suspicion within 24 hours to the parish health department or to the national surveillance unit. So it's passive in that way, depending on the provider to report, but also active because I have it in the other slide. Active because the hospital active surveillance nurse actually goes to the institution, looks in the admissions record, the A&E record, look on the maternity ward, the medical wards as well, to see if they find any women who were pregnant within the last year. Now, some of the ones that tend to be missed are those who are the late maternal deaths. So they may be admitted to the medical ward maybe 6 months after they deliver, but there is, in the history, there's no mention that they were pregnant 6 months ago or they delivered 6 months ago, because they're there for a condition that may not, in their estimation, be related to the pregnancy. And so those may tend to be missed. But there is always redundancy in the system, because when the cause of death is written up, then there's a pregnancy checkbox on the medical certificate of cause of death that if they tick it, it's to be ticked for all women. Once you're female, it's ticked. So they tick that the lady was pregnant in the last, died while pregnant or died within 42 days of the end of the pregnancy, or beyond 42 days, they're supposed to tick it. And so if we examine the data at the Office of the Registrar General, which we do once it's published, we do examine the data and look if there are any cases that are registered deaths that we don't have on our system. So mention this class 1 notifiable condition. And for the maternal deaths, then I know I said women of reproductive age from 14 to 44, 14 to 49, 15 to 49. But for Jamaica, for the purposes of surveillance, and we have had deaths in 14-year-olds and so on. So for the purposes of surveillance, we do the surveillance from age 10 to age 50. So if they are between 10 and 50 and there's evidence of pregnancy in the last 12 months, then they are to be notified. If they die, the case report, including a clinical summary, goes to the Ministry of Health and also the Parish Health Department. An investigation is done completing a clinical summary a home visit is done and the home visit and antenatal report is written up. Postmortem is recommended for all maternal deaths. It's not mandatory unless it's a coroner's case, but it's recommended so that we can know definitively what the cause of death is. And the deaths are reviewed quarterly in each health region by a multidisciplinary team. So the medical officer of health is there, the obstetricians, the primary care team, epidemiologists, and we as medical epidemiologists, we attend to guide in terms of the classification of the cases and also to extract information as well in terms of the classification of the case. And then national review is done annually to present all the data for the previous year, the year that is completed. Now, at the reviews, we look at the delays and the interventions are planned and supposed to be followed up to see what interventions have been actioned, and of course we track to see if it's making any difference. And so we look then at the delay model. So we're looking at not the cause in terms of the anatomical or physiological cause of death, but what factors contributed to the death of the woman. And if we know what factors contributed to it, then we know how we can intervene or what interventions can be made to prevent similar deaths in the future. We can't go back because the women, they have already passed. But if a situation like this comes up, what can be done to prevent it from happening? So for each case, we ask, is it a delay 1, delay 2, or delay 3? So delay 1 is a delay in the woman's decision to seek care. So did she not realize that this problem was serious? She thought it was a normal headache and, it's not so serious, so she didn't go to the hospital right away. And as it turned out, it was really a signal for preeclampsia, and she ended up dying from preeclampsia, for example. Was she deterred in any way by previous experience with healthcare workers? Based on our experience there, she doesn't really want to go back because she didn't have a good experience, or maybe not so much for or context, but the low status of women, as in they have to be accompanied in some countries by a male, or were there resource constraints in going to the institution? Is it that she didn't have anybody to take care of her other children? So we look what factors were at play in her decision to delay seeking care. And then we also look, was there any delay too? So delay in reaching care, and whether it's a hospital or a health center. So was it far? Was she in a deep rural area and found it difficult to make it to the hospital? Or was it too expensive to get the taxi, so the cost of the transportation? Or was it that there are social impediments? So there's war going on in the area, so she can't get through, Those are issues that we would classify under delay 2. No, delay 3 is it's the institution. So she reached the institution, whether it's a hospital or a health center. So, but there are delay in receiving adequate care while there, whether it's poorly equipped facilities or lack of medical supplies or the attending healthcare workers are not properly, inadequately trained or, poorly motivated staff, or there's inadequate referral system, as in we try to refer to a higher level of care, but they can't accept the patient, or maybe there's no ambulance, to carry from one level of care to a higher level of care. All of those will fall under delay 3.
Question, Doc. Is this modified in any way? Because in my mind, I thought there were 4 delays. Delay 1 to 4, and
Right.
4 was with the healthcare. Um, so delay 3 was delay 4. Maybe I'm mistaken.
No, you're not mistaken. For some reason, and I've been trying to find out why Jamaica have the 4 delay model. But if you look at the literature, it's a 3 delay model. And what is done, so type 3 would be the 4. For type 2, it would correspond to 3. But what Jamaica does is to split delay 1 into 2. So delay 1 is split into 2. It's still all patient factors, but we separate it and say delay 1, she did not recognize the problem. And delay 2, she delayed in actually deciding to go and seek care. But they're so intertwined, I'm not sure why it was separated, but well, you clearly work in the healthcare system, so we are updating the surveillance manual to convert to the 3 delay model, because if we look at the delay 1 and 2 for Jamaica, they're so intertwined, and the lady having died, it's really difficult, and we argue a lot on the reviews, is it that she really didn't know that this was serious, or she just decided she's not gonna go? They're so interlinked, it's very difficult to separate, and the lady isn't there to really clarify for us what the thought process was. So we don't see any harm in putting them together. The data is already disaggregated into delay 1 and 2. So if we aggregate them as one, then we have delay 1. Delay 2 would correspond to delay 3, and delay 4 would correspond to delay 3. And we did consultation concerning the maternal mortality forms, and so those will be updated to reflect that, and got feedback from the midwives and the hospital active surveillance nurses and so on. So that is to come to keep us in line and make it comparable with what we're seeing internationally. But yes, we do have the 4 delay model. You're not mistaken. Right. So Thaddeus and Main, in their publication, Too Far to Walk, Maternal Mortality in Context, did a case report on this lady, Mary, who was seen in Sokoto. That's set in Nigeria. And I'm going to read it, and you can see if you can see the delays coming out and what kind of delays you're seeing coming out. Today, Mary, the lady who helps us in the house, came late to work. I told her off for being late and asked why. She said that one of her townswomen had died in the hospital while giving birth to a baby. This was her 5th delivery. She was not from a far off village, but from Sokoto city itself. She had not gone too late to the hospital, but rather gone on time. By the time they found a vehicle to go to hospital, by the time they struggled to get her an admission card, by the time she was admitted, by the time her file was made up, by the time the midwife was called, by the time the midwife finished eating, by the time the midwife came, by the time the husband went and bought some gloves, by the time the gloves were brought to the hospital, by the time the midwife was called, by the time the midwife came, by the time the midwife examined the woman, by the time the bleeding started, by the time the doctor was called, by the time the doctor could be found, by the time the ambulance went to find the doctor, by the time the doctor came, by the time the husband went out to buy drugs, IV set, drip, and bottle of ether, by the time the husband went round to look for blood bag all round town, by the time the husband found one, and by the time the husband begged the pharmacist to reduce the prices, since he had already spent all his money on the swabs, dressings, drugs, and fluids by the time the hematologist was called. By the time the hematologist came and took blood from the poor, tired husband, by the time the day and night nurses changed duty, by the time the day and night doctors changed duty, by the time the midwife came again, by the time the doctor was called, by the time the doctor could be found, by the time the doctor came, by the time the T's had been properly crossed and all the I's dotted, and the husband signed the consent form, the woman died. Today, the husband wanted to sell the drugs and other things that they never used to be able to carry the body of his wife back to their village, but he could never trace the body again in the hospital. So quite a sad story. It's a different context, but we can see certain things coming out. We're not seeing where the lady delayed in seeking care. She went to the hospital on time, but nurse had to finish eating. We know about the handover, and you have to wait until handover occurs here in Jamaica. Sometimes the doctor can't be found. Yes, sometimes the patient's relatives are sent not to buy ether or probably not dressings or gloves, but specific things they're sent to buy and sent to pay for, say, CT scan outside of the institution. So there are delays definitely on the part of the institution and type 2 too, because they did say that I think it was trying to get something to take her. Trying to find it. Yeah, by the time they found a vehicle to go to the hospital. So, you know, there were delays in trying to get a vehicle to take her. So would say delay in accessing care. That would be delay two. Um,
Wait,
definitely.
1 second, Doc.
Go ahead.
But it says she said that one of her, this was her fifth day. She was
Mm-hmm.
not from a far off village, but from
Mm-hmm.
Sokoto City itself. She had not gone too late to
Mm-hmm.
hospital,
Mm-hmm.
but rather gone on time. So she got there on
Yes.
time.
So she got there on time, but there's still issues with the transportation. So the issues with the transportation would be in delay too. But
Okay.
you know, um, I guess you would say there's not a delay because yes, she had issues with transportation, but since she got there on
They're on
time,
time, right? So
yeah,
effectively, it would be inconsequential.
yes. Always arguing about that as a gray area to say the delay is there, but it's a matter of whether the delay, if there wasn't that delay, if it would have made a difference. And so Do
Okay,
you
got it.
or yes, so the delay is there, but if it probably would not have made a difference, do we factor it in? Do we note it as something to work on in terms of infrastructure? Then maybe not. Maybe not, since it didn't make a difference. But as it is for teaching, so we may not record it in real life, but to say that if there is an issue with transportation, we put it under delay too. But if this is a real case that we're reviewing, we may not note that because since they said it's on time, she reached her on time, then we would, overlook that. Yeah. Thanks for that. Very good. We're always arguing about whether or not to include this or that based on whether or not it would make a difference. So sometimes we break down, well, all the time, actually, we break down delay 3, looking at the access to care. And in this case, it's not access to care in terms of getting to the hospital, but access to usually a higher level of care. So the service not available nearby, or the transport not available to reach the referral institution. So the ambulance isn't there to take you from a regional hospital to a tertiary level hospital. Or was she not treated immediately after arriving at the facility? Was there a long waiting time? Then those are issues that the facility would need to sort out. Was there a human resource issue? Lack of staff or lack of appropriate level staff? So, is this a complicated case that was left on the intern or SHO, that kind of thing? Did the intern or SHO not call or not escalate it to the consultant? Then those would be issues, lack of knowledge or skills of the staff, poor staff attitude, or, they just treat the patient bad, or other resource issues, lack of supplies or equipment, whether it be drugs, medication, sorry, same as medication, blood products, those kind of things would factor under delay 3. So if we're looking at some data now and looking at fertility and mortality, you could argue that if the fertility rate is going down, then really the maternal mortality ratio should go down too, because you have fewer births, fewer women presenting to hospital. And if we have the same staffing or even more staffing and have fewer patients to deal with, then the maternal mortality ratio should go down if it's just a matter of staff to patient ratio, or the other way around. Yeah. If it's just a matter of the staff to patient ratio, then we should have a decrease, but that is not what we're seeing. And many times we do the analysis of the maternal mortality ratio by triennium, as in we put 3 years data together, because the numbers each year, even though the maternal mortality ratio seems high, but in terms of the numbers, it's actually quite low in terms of trying to get statistical significance. So you may see 3 years grouped together, and that's the reason. But so sometimes we collate it, but sometimes we just look at it year by year, especially to track the SDG. We do it year by year. But if we're going to do statistical analysis or higher level analysis, then sometimes we do it by the triennial. So again, we're seeing the line in yellow, the number of live births So at the turn of the century in 2000, we had the live births, by the way, is on the secondary axis over here. So we have over 50,000 live births per year. And now we have less than 30,000 live births each year. In 2024, we had about 23,000 live births. So it's much fewer. And so we notice a steady decrease. A matter of fact, we are below replacement level now at the total fertility rate of, I think, 1.9. So even with that, the number of maternal deaths, it fluctuates. But if you draw a line, it may actually be quite flat, because in 2000, the number of maternal deaths was 47. But in 2024, it was 39. So number of maternal deaths, you could say, it's not really increasing. But in blue, we have the maternal mortality ratio. And if the denominator is going down, even if we keep the numerator constant, the overall calculation is going to increase. And that is what we're seeing. The maternal mortality ratio, yes, it does fluctuate, but is increasing. This at over 200 per 100,000 live births. That was in 2021 when we had the COVID pandemic and we had the Delta wave. The women then not vaccinated against COVID, and so we had a higher number of maternal deaths, much higher, 70 in that year. If we look at it by health region, in the Southeast and the Western region, they have tertiary level hospitals, Conroe Regional for the Western region, and we have the Victoria Jubilee Hospital and also University Hospital in the Southeast region, but theirs is increasing. And Western region overall, if we put a trend line, a linear trend line, it's increasing. For the Southern and the Northeast, it does fluctuate, but overall, none we can say is actually decreasing. If we look at high-risk groups, say the under 20, these are teenage pregnancy, and we look at the proportion of births in women who are under 20, that's decreasing, and the proportion of deaths in the under 20, with some fluctuation, it's actually decreasing. But for the women, this high-risk group, where we have the 35 and over ladies or mothers, the proportion of births that occur in the 35 and over age group is actually increasing on average over the years. And so too, the proportion of deaths. As I said, these are the ones who tend to enter the childbearing with comorbid conditions, including diabetes, hypertension, and may tend to be obese. For the grand multiparous women, the number of births decreasing. Because if you think about your grandparents and your parents, there's a difference. My grandmother had 10 children. When it came to my mother, she had 3. And for me, I had 3, but I have to help the fertility rate, because if it's at 1.9, no, I'm just trying to increase it a little, so I went a little above average. The average to maintain is 2.1 per couple, so I just went a little above. All right. So the grand multiparous women, people not having that many children, so it is decreasing, and their proportion of deaths that occur in this group, it does fluctuate, but not as high in the last 10 years or so. So if we look at it just by the age groups now, under 20, usually the maternal mortality ratio is less as as the age increases, then the maternal mortality ratio increases. So this 35 and over, higher than in the 20 to 34 year age group. And it is actually the teenagers that have the lowest maternal mortality ratio if we look at it by age. For the parity-specific maternal mortality ratio, the primiparous women, those are the ones in their first pregnancy that I guess you would say would be lower risk because their maternal mortality ratio is the lowest over the years, has remained the lowest. And even though in other groups, it's going up, but the 2 to 4, yes, higher than the primiparous, but those, the grand multiparity, those are at highest risk for maternal deaths. If we're looking at the timing of the death, when do they occur? Is it while the women are pregnant, within 6 days of the end of pregnancy, or between 7 days and the end of the puerperal period at 42 days or 6 weeks? Then we see that most, as in the highest proportion, 34% of them, and this is just combining the data from 1998 to 2024, most of them occur in the within 0 and 6 days of delivery. And another quarter of them die while pregnant. And then we have those within 7 and 42 days of the end of pregnancy. Now, with advances in the care of these mothers, then you have them surviving to later, and they go on to survive. But even though the insult may have occurred during pregnancy or during delivery, then they go on to 42 days. Now, another maybe 1/5 or so occur, and they would be the late maternal deaths. For the coincidental deaths, and in Jamaica, the coincidental deaths tend to be because of gunshot wounds and motor vehicle accidents, and those tend to occur by and large during pregnancy, most of them during pregnancy. All right. So for the maternal mortality ratio, direct deaths tend to predominate. Over the years, direct deaths predominate. You can see higher bars, and this is by triennium from 1998 to 2024. So higher bars for the direct deaths, followed by the indirect deaths. Now, in this triennium that is 2019 to 2021, you found that the indirect deaths was much higher. And that was because in 2021, we had a lot of deaths. I think about 40% of the deaths, the maternal deaths that occurred in 2021 was actually due to COVID-19. And so you had a spike in the indirect deaths in that triennium. The late deaths, fewer, but fewer than the direct and indirect deaths, and still fewer coincidental, but actually tend to be increasing. And if we look at the causes of these direct and indirect deaths, if we look at it by cause, then direct deaths tend to be due to the hypertensive disorders of pregnancy. So pregnancy-induced hypertension, usually after 20 weeks of pregnancy, and preeclampsia and eclampsia would be the cause. And that's followed by obstetric hemorrhage, usually postpartum hemorrhage, and you have obstetric embolism. That would be the pulmonary embolism. And so those would be the top three direct causes of maternal deaths in Jamaica over the years. Of course, we see the shift from where we have in blue hypertensive disorders featuring but decreasing as we had UE physicians, I think, for the in 1940 something, 48, I think, when we had UE graduating doctors. Of course, that we start seeing a decrease, and there were interventions over the years. The primary healthcare renewal and population policy, Jamaica perinatal survey was done during 1990s. And so we see the change in the profile, reduction in the hypertensive disorders of pregnancy, reduction in hemorrhage, and that's usually postpartum hemorrhage, and the indirect causes of maternal deaths, but they still tend to be higher than sorry, I think I said it wrong. Reduction in direct causes of maternal deaths over the years, but the direct causes still tend to be higher in number and contribute more to the maternal mortality ratio than the indirect causes. So if you look at the causes of the indirect deaths now, those would usually tend to be circulatory disease. We have a lot of sickle cell disease. We still have some HIV, AIDS, and respiratory disorders that featured very high as indirect cause for the 2019 to 2021 triennium. And we have some cancers. Other indirect causes would include things like SLE, some infections like dengue, and so on. All right. All right, just looking at the maternal death surveillance and response, the idea is to start with the low-hanging fruit. Look, if we do the review and we say we know what the leading causes are, we see where are the gaps in resources in the health system, then those would be what we need to address, to prioritize those causes with high prevalence, the causes that will the factors such as those with human resources, maybe that could be addressed. And whatever recommendations we make at the reviews, then those are to be incorporated in the health plans, in the budgets for the regional health authorities. And the idea is to use the evidence-based approach. So we collect the evidence based on reviewing each maternal death. The evidence is that these are the leading causes. These are the delays that we're seeing. And so these are the things that need to be addressed. All right. I think I touched on the case review process, but just recommendations, the idea to look at similar cases together. That's not always possible because there is a timeline for reviewing the maternal deaths. And if we're going to wait on, say, another postpartum hemorrhage, death due to postpartum hemorrhage to occur, then it would delay the time to review them. But if they're reviewed together, then we can look at the common factors that need to be addressed for those particular deaths. All right, look at addressing service delivery deficits and changing the attitude of staff toward the patients. That would be a more difficult one to address in terms of you learn about behavior change and so on, but that might be more difficult to tackle. Look at training opportunities for the staff. I'll touch on that a little bit more, and putting out proper guidelines in terms of monitoring and evaluation. Then if we make decisions that specific things need to be changed in the region or a particular institution, whether the staff need to be trained in management of postpartum hemorrhage, or at a consultant or post-DM person need to attend all high-risk C-sections, then we need to evaluate to see and review and do audits to see if this is actually happening. So that's one of the deficits that need to be tightened up on. In terms of the surveillance, are they indicating the proper cause of death on the medical certificate of cause of death, such that when RGD record it, we can always track these deaths or find the deaths, such that the civil registration and vital statistics system properly represent the maternal mortality ratio. That is a deficit. So physicians need training in that. And so, yes, we have been doing training in that, collaborate with the Ministry of National Security, in particular the forensic pathologists, to get the information from women who die, who don't die in the institution, but not, the cause may not be coincidental, but just sudden death, but they tend to be coroner's cases. We have difficulty getting their postmortem, and so we don't know what caused the death, so difficult to address those causes. So let's make some recommendations. If we're looking at the 3 delays model, then delay 1 would speak to the patient's decision to seek care, whether she didn't recognize the problem or she just decided not to seek care early. And so we need to, 1, improve the health literacy of the patients, let them know what are warning signs for serious conditions, encourage them to seek care early. If you have any bleeding whatsoever, abdominal pain, if you're having certain types of headache, then you need to seek care. Those kind of things need to be reinforced. Advise on the type of facility that they should go to for care. Because some patients, and I know when I was in the health center, some of them end up at the health center, and these are serious emergencies, have severe preeclampsia, and then you have difficulty transferring them because you can't just send them in a car to go to the hospital. You have to call the ambulance and start the management. When, if they had gone straight to the hospital, chances are, I'm not saying that there aren't issues with waiting time, but chances are they might have been seen right away, and there wouldn't be that delay in trying to get the ambulance to come to the health center to take them there.
But the opposite is true, Doc.
Hmm?
To cut you there, the opposite is also true. Or at least I should say the contrapositive is true as opposed to opposite
Mm,
because in my
yeah.
experience, one particular experience that highlights the the contrapositive of that is having sent a patient to the hospital. The patient sat there the day before on a chair, didn't get through, and then the following day, when she came back to me, far less stable, I was able to write a letter, appropriately worded, and send her on our ambulance. And she got through a lot quicker because they were, I having done that first level of assessment that unfortunately she was not afforded at the hospital. We were able to accelerate her care because she was sitting in a chair and everybody thought that it was nothing. So I'd say we do also acknowledge that the patient does not know, well, patients in general, not just pregnancy, patients in general don't often know what constitutes a medical emergency in certain specific situations. And their first step is go to a doctor. And then that doctor makes the appropriate, decision, best practice decision. And in that specific instance, we were able to accelerate care that she otherwise would not actually did not receive because she went and she didn't get through. So it can accelerate, just to say one. And two, the books, the antenatal books, just as on a point of health education and promotion, you know when you flip through the books, I think we've all seen the books. It does
Yeah, there's a page
highlight.
there. Yeah.
Right. So there, I guess, I guess we are making efforts here, but definitely room for improvement. That's
Mm-hmm.
it. Thank you.
Yeah, thanks for that. To the antenatal books, so there's a page in it that say if you're having any of these symptoms, then have to seek care right away. Um, so it's in the book. It's in the book, but I'm not gonna assume that all the pregnant ladies gonna read it. So of course, when they come to antenatal clinic, we have to be the ones to highlight it to say, you see all of these symptoms. If you're having any issues there, then um you have to seek care right away. And I take your point. I mean, sometimes it work out, sometimes not. I find too that making contact with somebody at the hospital to say that this patient is coming, although not always practical, that helps as well. So they can expect that patient is on their way, or patient with a specific condition, something that is serious that can't be ignored, need to be seen. But I've had very nervous, very nervous times at the health center with lady in with severe preeclampsia there in the health center, and we don't have any mag solve, but it's almost like, please don't fit here, please don't fit here, waiting for the ambulance to come. But you're right, there is no guarantee that if she went straight, she was gonna be assessed right away. Um, I don't know what you say. I don't know. Sometimes it works, sometimes not. Um,
Yeah, it is honestly, it is a gamble in a sense. So I guess, yeah, it is. Absolutely.
mm. Um, for the gosh, that would bleed. This not sure where we stand on the COVID-19 vaccine. Probably should have updated this slide. But what we found during the pandemic is that all of the maternal deaths, all of those ladies, they did not have the COVID-19 vaccine. So we know that there are barriers to women receiving vaccines during pregnancy, even the influenza vaccine. So that's a gap that can be filled because more and more we're having, well, for COVID, we had so many deaths, 40% of the deaths in 2021 of the maternal deaths was actually due to COVID-19, and none of them were vaccinated. So it was to make a plug for educating the women on the benefits of vaccine, maybe making the vaccines available at antenatal clinic. But yes, maybe COVID not keeping no, but then it would be more relevant. For sure, influenza is always keeping. So I know that pregnant women are this is one of the priority groups along with the elderly and the healthcare workers for getting the influenza vaccines each year, but there is difficulty in getting them to take the vaccine. So there needs to be health promotion in that area. For the staff, training and retraining of the clinicians in the clinical guidelines, because there's high turnover of staff, even on the obstetric wards. If we look at the leading causes of maternal deaths, then of course there should be a thrust to ensure that there are accessible guidelines to address those causes, such as hypertensive disorders of pregnancy, postpartum hemorrhage. And I know that some of these guidelines were developed over the past few years and disseminated. So there is a thrust to address those leading causes by updating and disseminating the guidelines. If there is a near miss, and this is a lady who's pregnant or within 42 days who would have died but survived a very serious complication of pregnancy. So when this happens, or if there's a maternal death, have debriefing right away or soon after in the institution to see what happened, how can we treat this differently in the future to prevent it from happening while it's still fresh in the brain. Another recommendation, maybe have facility-specific algorithms for specific conditions. So what may work at Victoria Jubilee Hospital may not work at Salve Hospital. So you have an algorithm for management of postpartum hemorrhage, but what needs to be tailored to this institution, then it can be tailored. Of course, go ahead. Somebody saying something? Okay. So for the institutions, difficulty streamlining the process of transferring the patient. Now, patient with certain complications should not stay, for example, at a type C hospital, but type B, A hospital saying, oh, we don't have any space. You don't have any space, but the type C don't have the facilities, the expertise. So there has to be some give there, because too often patients are there, and by the time the space become available, the patient is too unstable to be transferred, and then the patient ends up dying. So that process needs to be streamlined. And if it is that essential equipment is needed, whether it's ultrasound, CT scan, some of these, they are present in the institution, but tend to be down, so they need to be fixed or repaired. And there is some dust, well, not sure how soon, but to have kind of rental of this kind of equipment, such that the burden to repair and to maintain would be on the private providers rather than on the public purse. And look at inadequate supplies for blood products, for drugs, for anything that is lacking. The ICU, HDU space may need to be expanded at regional hospitals to prevent patients having to be transferred over long distances. If there is some recommendation that was made and is to be implemented, then there needs to be audit done to do some M&E to see if this was done or not. And if not, who is, as in, there should be, somebody should be responsible for fixing it. And at, I don't know, I say 6 months, but there are some that will be shorter, could be done in a shorter time period. But the idea is that there has to be some audit and people have to be held accountable if things are not followed up. So on to the conclusion, we spoke about the obstetric transition and where we had high fertility, high mortality, and we had a high communicable disease burden, really nothing really being done to prevent maternal deaths. And we moved toward higher NCD burden. We have over medicalization, increased institutionalization of the mothers. But with that, we have lower maternal mortality ratio. But the systems have to adapt to the changing profile of women of reproductive age because the challenges that emerge now would be non-communicable diseases, diabetes, hypertension, especially since women are delaying childbearing to later in life. We have the over 35-year age group. Their fertility rate, or no, let me take that back. The proportion of births in this age group is higher or at least the same as before, but their maternal mortality ratio is higher than those in the lower age category. So how are we going to manage that to ensure that they get the adequate reproductive health counseling, or they get the appropriate management, whether it's high risk clinic or appropriate follow-up by a certain level of physician, for example, or specialist care for those persons, since you can't dictate how many or when people have their children, but we still want to reduce the global maternal mortality ratio to less than 70 per 100,000 live births by 2030. And Jamaica needs to contribute to that. And if we are to contribute to that and have a maternal mortality ratio of less than 70 per 100,000, then based on where we were in 2024, we have to reduce by at least 12%. If we have a linear reduction, then at least 12% each year to achieving that. And when we do the reviews, the idea is having evidence, is to make evidence-based decisions. And so if we know the leading causes of death, we know what the delays are, then those are what we need to address. And the delays that we're seeing is primarily type 3 delays related to infrastructure, equipment, expertise, human resources, and coordination. So these are the things that need to be addressed if we're to achieve our goals. And we have come to the end. So if there are any additional questions or comments, please go ahead. Into the chat. Laugh out loud? Okay, when was that? I don't know. Dr. Thorpe, what were you laughing about? That was a long time.
When you were sharing your contribution to the
Oh, the
dropping
fertility
the
rate,
fertility rate,
yes.
right?
And I encourage you all to make your contribution before 35 for the women. The men, you know how that work. Yeah. Yeah, but I don't know if anybody else have the same experience, but that's how in my family, my grandmother, 10 children, and then it reduced, and you know about the two is better than too many campaign and how that worked probably too well, and now we're below replacement level. But even with fewer births to attend to, our maternal mortality ratio is still not where we want it to be. All right. Did I say good night then? All right, good night. I will come back tomorrow face to face at 4:30 for outbreak investigation. Night, everyone. Signing off.
Good night.
Good night. Thank you.